third session of the first day by inviting on stage a speaker who has already delivered quite an insightful discussion in the first session. We'd like to welcome back Dr. Beena Hameed, ladies and gentlemen.
So thank you very much again for the introduction and invite. So I'll be talking about the recent updates on Scleroderma. Okay, so no disclosures again regarding this talk. Thank you. So we know that Scleroderma is a rare autoimmune disease, but then unfortunately patients who do get it, it's a bad news for them because up till now we didn't have much therapeutics for these. Mostly it was a symptomatic control. However, with recently we have got some light in the tunnel, so some data suggesting some hope for these patients. But most of the studies been done on early diffuse systemic sclerosis, so your careful selection of the therapies are needed. So we're going to go through these trial data. However, first is to examine the morbidity and mortality, as we know that the disease is associated with high morbidity and mortality. Then the next step is to make sure that you screen these patients in time for the diagnosis and also to know the organ system involved. So when you look at the morbidity and mortality of this disease, important thing is to know that there are three important mechanisms which result in disease. And namely, they are vasculopathy, fibrosis, and autoantibodies play a great role. So your vascular complications include Raynaud's and its severe complications, pulmonary hypertension, and renal crises. And the fibrotic manifestations are interstitial lung disease, gastrointestinal involvement, cardiac and musculoskeletal involvement, and of course skin. It can be a combination of both. So it's really important to assess these patients in a timely manner to get to the bottom of the diagnosis and the system involvement. So generally speaking, the two main groups are the limited cutaneous scleroderma and diffuse scleroderma. Limited makes most of the patients, more than 50% of the patients, whereas the diffuse variety is seen in about 1/3 of patients. But then there is a very minority of patients get something called sign scleroderma, where you do not see any skin manifestations, but they have internal organ involvement, and it could be very tricky to diagnose them. So there are certain serological markers which help us not only diagnosis, but also to point to what organ system could be involved. There are antibodies which are seen in a diffuse variety, and some antibodies point towards the limited variety, and also some would tell us maybe this patient have overlap diseases as well. And also the antibodies will tell you which organ system is going to be affected in this patient. So similarly, here you see the mortality in systemic sclerosis. If you look at the sign scleroderma, there is delayed morbidity mortality, but then it might plateau at some stage. However, when you look at the diffuse and the limited varieties, the diffuse progresses quickly as compared to limited variety, but eventually they meet at some point. And if you look at the different organ manifestations, which you expect more high mortality in this patient, is the interstitial lung disease is the topmost, followed by the pulmonary hypertension, and then you have digestive system involvement. And fourth is the scleroderma renal crisis, which was a few years ago was the most mortality-related manifestation, but there is an improvement in the standard of treatment, which has really improved the outcome. And then there are certain few others which also contribute. And if you look at these serological markers in this paper, you could see different antibodies. The presence of them also determines the mortality. But if you look at closely the association of these antibodies, it explains. So you see anti-polymerase 3 antibodies. You can see this carries a higher mortality, about survival rate, its lowest mortality survival rate being 92%. The intermediate is the anthracenture antibody, which actually is most seen in limited cutaneous variety, so it's got a limited mortality. Whereas if you look at the SCL70, which is associated with interstitial lung disease, it carries higher mortality, as we saw earlier on. So I'm going to speak mostly on the cutaneous and the lung disease, in particular interstitial lung disease, because these are the areas where the recent updates are there. The rest of them, in the last few years, we haven't got any robust data. So cutaneous disease, as such, it is the diffuse variety. You see the skin is affected the most. And it is associated with other features such as tenosynovitis, tendon friction rubs, inflammatory arthritis, and joint contractures eventually because of the burden of the disease. And limited cutaneous, it is affected less. Also, we see the natural history of the diseases, so the skin does improve over a period of time to some extent. So these are the different drugs which we use. I would not go into details of those which has only made to phase 2 studies. So mostly discussion would be those who would be into phase 3 studies, because that's more clinically relevant for the clinicians or practicing rheumatologists. So this is the modified Rodnan skin score. This is the tool which is used in clinical research to gauge the success of a drug. So I think a little time to spend on to understand what are these. So basically, if you look at the pictures, you kind of find out the flexibility of the skin and grade it as 1 to 3 in terms of severity of skin involvement. And you choose 17 different areas to then give a score up to 51 as the worst. And then there is also known that if there's higher skin score at the beginning, there's more likely to be internal organ involvement as compared to if the scores decline, it causes softening of the skin. And if you look at the numbers, it's the minimum of 3.5 to 5 point improvement, which is taken to be significant in the clinical trials. So this is a PREDS trial, which was done to assess the efficacy of oral prednisolone in the skin disease of systemic sclerosis. The trial was done in UK, but unfortunately, halfway through the trial, because of the COVID, they had to make it open label, so the data cannot be extrapolated into clinical practice. However, if you look at the graphs, there was improvement as a primary endpoint as modern skin score, and you can also see the primary end of HAQ-DI. And similarly, there were secondary endpoints like pain score, happiness scores, patient-reported outcomes, and also the anxiety scale. So there was some improvement noted. But again, it's very difficult to interpret the data in terms of the strength of the trial wasn't great. So there has been 2 important trials for methotrexate. And one trial was giving intramuscular methotrexate, and the other trial was for oral. But both the trials did show improvement in the skin score when they were given to patients as compared to placebo. You can see the green bars are going up and the yellow bars are going down. So certainly there was improvement. Hence, we do practice giving methotrexate at the early stage. And this is a slide from the Scleroderma lung study 2, where cyclophosphamide was compared with mycophenolate. And if you look at there was improvement, both the arms. However, it wasn't very significant. So, and as we know, in the clinical trials, it's not only the efficacy, but we also look for the safety data. In terms of safety, mycophenolate was a safer drug in terms of complications. So the conclusion of this trial was that patient should be given mycophenolate over cyclophosphamide when the skin disease is concerned. And however, in this trial, skin disease was actually a secondary endpoint, because within the trials, the primary endpoint weighs more than secondary endpoints, but there was meaningful conclusion. Then this is the recent trial of tocilizumab in a focus trial. You could see the primary endpoint was actually skin data, and then the secondary endpoints were lung-related. So you could see the primary endpoint, although on the graph you would see some improvement, but the primary endpoint was kept very high, like 30% improvement in the skin score, which didn't meet the primary endpoint. But there was some improvement needed in the secondary endpoint, which we're going to look at when the lung data is, I'm going to go through the lung slides. Riociguat, again, in this patient, this trial was negative for the skin. Again, slide might show improvement, but we look at the p-value, significance value, it wasn't significant. Sorry, I'm rushing because I've been given already a time alert. So this is our rituximab data, and primary endpoint at week 24 was the skin data, and the lung data was secondary endpoints, but you can see the lines are diverging, so, and p-value is very significant, so certainly rituximab was one of the drug which is considered to be very good for the skin disease. Abatacept, this is actually a safety and efficacy phase 2 trial, but here there wasn't much significant difference in the patients who were given abatacept or placebo. Can I have some water, please? So certainly it was a negative trial. So the most important improvement in the skin disease was noted in the trial with autologous stem cell transplantation, but we all know that there is always toxicities, thank you so much, associated with this when you're priming your patients with cyclophosphamide or other immunosuppressive therapy. So certainly good data for autologous stem cell transplantation, but you have to be careful about the toxicities, and you would only recommend if all other therapies been failed and you have careful selection of early diffuse disease with minimum organ involvement. So this is a summary or meta-analysis of all the trials, which was published earlier on this year by Janet Pope, and you can see the highest impact is with autologous hematopoietic stem cell treatment, and then your methotrexate, cyclophosphamide, and as you go up. So that sort of gives you idea through the clinical trial which drug has highest evidence for the skin disease. So, so if you see, maybe first line is your methotrexate, in particular if the patient has associated arthritis or myositis, and if it's a lung disease, like interstitial lung disease, you go for mycophenolate, and then third line might be rituximab, tocilizumab, and cyclophosphamide, and lastly is the autologous hematopoietic stem cell therapy. The venous could be sometimes a very complicated disease. In patients, you might get gangrene, ulceration can be very painful. And there isn't much advances on this, but usually your first line is calcium channel blocker, then PDE5 inhibitor, prostacyclin analogs, or you invert them as a third line, and then there are certain other supportive treatment. So interstitial lung disease related to scleroderma. So we know about 1/3 of patients might get interstitial lung disease. It's more prevalent in the diffuse than limited subsets. It can happen anytime during the disease, but usually more prevalent in the first 3 years. 50% do progress significantly as per USTAR data, and the strong association is made with SCL70 antibody, and certainly gastroesophageal reflux disease contributes. And you look at the other side of the graph, you can see the rapid progression of interstitial lung disease as is shown on the last picture on the slide. So screening is important. How do we screen? You need HRCT and pulmonary function test as baseline, and depending on if they are normal, you just follow them every year until the disease is stable for 5 years. Whereas if the CT is abnormal, then if it's less than 20%, it's limited disease. More than 20% is your diffuse disease. You certainly treat the diffuse disease and follow them on. In terms of screening, so you ask for respiratory symptoms actively. You auscultate for the crepitations, pulmonary function test, and then your HRCT. And if these cannot explain the dyspnea, you do look for pulmonary hypertension. So treatment criteria includes if there is less than 80% involvement, but there's any degree of ILD on HRCT you treat. More than 20% total lung involvement or HRCT, more than 10% involvement with abnormal liver function, and high-risk factors would carry these serological markers, even if they have milder disease on CT, and certainly if the symptoms are worsening. So these are the different medications recommended. And tocilizumab and nintedanib is the only one which is so far FDA approved. Rest are not. Azathioprine, the study wasn't convincing as compared to cyclophosphamide. The azathioprine didn't help to improve the outcomes. Scleroderma one study, here you see the cyclophosphamide was given with placebo on the second arm. Cyclophosphamide given was stopped at 12 months, and the patients were followed up for 24 months. There was improvement, but eventually there was a decline at week 20, month 24. So certainly over 2 periods, it wasn't so effective. Mycophenolate mofetil versus cyclophosphamide, as we saw in the skin score, similar messages are seen in here, that mycophenolate is equally effective as cyclophosphamide is, but certainly safety data helps you to determine that you go for mycophenolate first. And rituximab, this trial, DESIRES trial, you see safety and efficacy of rituximab. And here you can see again the lines are diverging at the end at week 12. Certainly it was a positive trial from that point of view, a good lung data. And you look at the other parameters, certainly on ongoing trial, the extension of the trial also gave the similar message, more so for FVC than a DLCO. Intravenous cyclophosphamide also compared with rituximab, similar messages, equal efficacy, however, less side effects with rituximab. So that is the decision that you can made on your trial, from this trial in your clinical practice. Tocilizumab, again, a very good data in the phase 3 trial, FOCUS trial. As you can see, the lines are diverging. And the phase 2 trial, which was a fascinating trial, which were done before the phase 3 trial, as you know, again, there was a stabilization of lung functions. So this is the reason why FDA approved this drug for pulmonary fibrosis or interstitial lung disease. Nintedanib is an antifibrotic drug, but again, a very good trial. And as compared to placebo, the lung function test was maintained. And the current practice is to use it as add-on therapy most of the time after mycophenolate fails or you had a partial improvement with. Risogate, again, data wasn't great, but there was some potentials, but they said probably need more trials on that. Abatacept, again, there wasn't much to suggest as a standard treatment on this trial. Again, autologous stem cell transplant, the primary endpoint was the progression-free survival, which you can see on the last picture. It just sort of plateaus, and then certain other parameters also were successful. So was your lung data, FVC improvement, DCLO improvement, and HAC scoring. So certainly it was a positive trial. But again, careful selection is important. So the summary of the treatment is to start with 2 to 3 grams of mycophenolate, and you add on nintedanib if you don't see improvement or partial improvement. However, even if patients you can't tolerate mycophenolate, you can use nintedanib as a monotherapy. Then you go on to tocilizumab, and it's been seen patients who had acute phase reaction, they actually responded well. Then rituximab or cyclophosphamide, then hematopoietic stem cell therapy, and lastly, the lung transplant. And of course, you have supportive treatments such as PPI for reflex disease, smoking cessation, vaccination, and pulmonary rehab, antibiotic prophylaxis in case where there's recurrent infections, supplement oxygen if it's patient's hypoxia on exercise or lying down, septin prophylaxis if immunosuppression is given to these patients. They're prone to pneumocystic disease, and certainly if you have to look for the associated pulmonary hypertension. And of course, you would monitor the symptoms, these lung function, and you would try and wean them off if they have been stable for at least 2 years on these treatment and see if you can stop them at some point. So this is the new EULAR recommendations, which have not been yet published. All I wanted to show was the grade of evidence. You look at the different domains of the disease, and you can see A, B, C, D grading. I won't go into detail because I think I'm not left with much time because I believe I'm going to get the, sorry, no time. But quickly, if you look at the RANOs, the most important is your phosphodiesterase 5 inhibitor, iloprost. Digital ulcer, again, you have PD5 inhibitor, bosentan, iloprost as a strong evidence. For pulmonary hypertension, you have your PD5 inhibitors, endothelin receptor, and then prostaglandins. Again, iloprost and suicibet as grade B, and of course, they would recommend not to give warfarin because, again, the problem is these patients might bleed from GI because of the vascular ectasias they have. Skin, highest is your bone marrow transplant or hematopoietic cell transplant, rituximab, methotrexate. Then comes mycophenolate and tocilizumab. And for interstitial lung disease, again, hematopoietic stem cell transplant is topmost, rituximab, mycophenolate, cyclophosphamide, nintedanib, tocilizumab as level B. And then you have, for other manifestations, the evidence remains just symptomatic or there's no high-grade studies on them. So in summary, you have to identify your patients early enough to benefit from the therapies, because therapies usually work earlier when you give them. You have to find out the internal organ involvement and monitor them closely, and this is the only way you can survive your patients longer. Thank you.
Dr. Beena, ladies and gentlemen, we can't thank her enough. On both occasions, she provided us with invaluable insights.